Hi, Bettina and others. Can everybody hear me?
Yes.
Okay. So welcome everybody to today's CMR Journal Club. And I'm very excited today because we will start basically a little bit of a new era. I'm very happy and proud to have Bettina Bessler from now on as co-host. So we'll share the responsibility for this regular meeting. And so I will, without further ado, hand over to Bettina to lead today's Journal Club.
Thank you very much, Matthias. It's a great pleasure. So welcome also from my side in these really exciting times, even for us Europeans. We are looking abroad and seeing what happens there. So we are quite excited. Thanks very much for the two speakers today for joining us and presenting their papers, which are really exciting ones, I think. And yeah, so let's start and jump right into the first paper, which is a paper by one of my new colleagues in Zurich, Malgorzata Polacin. And the paper is titled Novel Magnetic Resonance Late Gadolinium Enhancement with Fixed Short Inversion Time in Ischemic Myocardial Scars. So Malgorzata, please tell us something about your paper.
Yeah, so warm welcome from Zurich. And yeah, so my topic is about LG imaging. It's very important. I was 1 year fellow at the group of Dr. Manka and now also my colleague Bettina Bessler. So we have many patients in our department every week. So our protocols are short and we try that they are efficient, but reliable visualization of LGE is very important. So we I want to present one possibility of LGE imaging with enhanced visualization of subendocardial infarction with a not really novel sequence, but it's based on 3D LGE imaging with a short inversion time, a very different image impression. We have dark scar tissue, bright blood pool, and very bright or nearly white remote myocardium. And it's a very easy sequence to perform. We don't need look locker, and we can just perform it at a fixed inversion time of 100 milliseconds after a waiting time of 10 minutes after contrast administration. So let's dive in. We had 64 patients enrolled. All patients had chronic ischemic scars. They had fully diagnostic data sets. We established the sequence in our protocol for patients with known and suspected coronary artery disease. And also it was easy to perform because we perform 3D LG imaging. So all the LG imaging is quite short. It's a sequence that is acquired in 25 seconds as normal 3D LGE. Yeah, so they are identical, to be honest, short LGE and normal LGE, except for the inversion time that is fixed at 100 milliseconds, not adjusted after look locker sequence in standard LGE. And so you don't need a look locker and you don't need a physician to tell the technician, please adjust LGE at 220 milliseconds, for example, but it's just performed and it's quite reliable. So that was included in our protocol, and afterwards we had two readers to look at the images. I wanted to show you. So that was quite our readout. Both images or both sequences, normal LGE and short LGE, was presented at the same time, and two readers had to identify scar tissue, to localize them, to describe the scar visibility, scar transmurality, and other features like right ventricular infarction or papillary muscle infarction, all thrombi, for example. So we discovered that the visibility of infarcts was better in short LGE than in normal LGE. When we jump here at this picture, like the best spot where I always miss subendocardial or small infarcts is apical inferior, is my favorite spot. Here, when you see at short LGE, it's a small transmural infarction. It's better visible than in the upper part, just because the contrast between blood pool and scar tissue is better. So we also discovered more infarcts or more infarcted segments than in normal LGE, for example, here in segment 9, because we don't see here scar tissue really. And also we didn't miss any infarcts seen in normal LGE. We all saw them also in short LGE, and some more, 6 more. It was a small cohort of only 64 patients. And also we detected all right ventricular infarction, papillary muscle infarction, and thrombi. We then measured signal intensity ratios for between scar and blood, scar and remote myocardium and blood, for short LG and LGE. So we were a bit surprised because the signal intensity difference is not so much more. It's significant, but still not so high as we would expect it from here, because I think from the eye, the contrast is quite good, but in the numbers, it's okay. And here we also see the big disadvantage of short LGE, because between remote myocardium and blood, the contrast is quite poor. So because the blood pool is grayish or bright gray, and remote myocardium is quite white, so the contrast here is poor in a contrast to normal LGE. The other big limitations are we saw more infarcted segments in short LGE, but we don't know if they are real or just impression. We don't have confirmation in a histological model. Also, the transmurality of some infarcts, for example, here in segment 7, I would say maybe 25%, and here I would say up to 50% transmurality, but we still don't know, is it 25 or 50, because we don't have pathology, still all living patients. And also we performed all our patients or protocols on a 1.5 Tesla machine. So if you would use a 3 Tesla machine, we had to adjust the inversion time, or the fixed or short inversion time, because T1 realization times are longer. And also we used one vendor where you can very easily adjust inversion time. For example, for some Siemens or some other vendors, it's not so easy to manually adjust inversion time below 150 milliseconds, because the machine knows there is no possibility to perform normal LGE with 150 milliseconds. So it's like mistake, and you have to avoid this. You have to try to manually adjust this. And in some vendors it's easy. In some vendors it's not easy to go below maybe 200 milliseconds. Yeah, and yeah, that's all I have got. Ready for questions. Yeah.
Yeah, thanks a lot, Malgorzata, for this interesting presentation. So if there are any questions, please put them in the chat, and we try to answer all of them. There are no questions right now, so maybe I start with one. So this is, I think it's really interesting. I hadn't seen this before, so I saw it for the first time once I was in Zurich. What would you say? How do you use it in clinical routine right now? Is it an additional feature? Do you use it in every patient? What would you say, especially for the future, maybe added diagnostic value of the sequence?
So to be honest, it's really valuable. I know maybe it's like not rocket science because it's quite easy, but for me or for technicians, before they perform a locker, they first do this short LGE. So we have like a queue maybe where could be the infarction is to be, and maybe so we know, okay, we have infarction there, we should really see and perform normal LGE more, I don't know, we try to null it very, very nicely. So because we know that's not a normal patient, it's like infarction there, and it's visible with one like, glance of like, we see it immediately because the contrast is so good. Also with patients like nulling is difficult, or they are very, I don't know if they are not compliant, you still know, okay, something's wrong, and you don't have only the wall motion abnormality like in cine images, but you have not really confirmation, but you need, oh, here's something dark in the posterior wall that could be an infarction. So somebody's more aware that something's wrong, or there could be LGE. So
it's sort of a screening sequence.
Yeah, yeah. And also technicians love them because they don't have to wait for an
yeah.
grabbing a copy or something and
okay, thanks. So Matthias has a question.
So it's more a comment than a question. I'm very, very happy and congratulate you for the study. In fact, we published a paper a couple of years ago from Calgary. Anna Chiara Aldrovandi is the first author, where we also used short and long inversion times. And what we saw that infarcts, subendocardial infarcts, but especially papillary muscle infarcts, were almost invisible in the regular, but were very well visible using a short inversion time. And the limitation you mentioned, that the contrast between remote and blood is not that high, to me, that's not a big limitation. I think it's still possible. And, you know, one could say, who cares if it's remote myocardium and blood? That's fine. We don't necessarily need to see that, as long as we can see even small subendocardial infarcts. So I sincerely hope that others pick that up and try that and use that. It has been, in my experience, extremely helpful in small infarcts, and especially when they're subendocardial or, as I said, in the papillary muscle. So congratulations.
Yeah, I agree. So yeah, we have two other questions. The first one, how much flexibility do you have on timing post-GAD for these images using fixed TI of 100 milliseconds?
It's a very good question, because I already mentioned maybe the benefit of the sequence is not so big if you have 2D LGE imaging, because you have to wait quite long for a short axis stack. And so the answer is I really don't know, because they are so short, like one short axis LGE takes up to 25 seconds, 25 seconds. And afterwards we perform this short LGE, or before, right now we do it before normal short axis 3D LGE. So the time's about 1 minute, maybe 1.5. So I think if you wait 5 minutes or 10 minutes, I didn't try it until now, to be honest. We always perform it very quickly after, quite strict after 10, 12 minutes of gadolinium administration. So I don't know, to be honest.
Okay, so further studies are needed.
Yes.
Like every time. Okay, the next question is, I wonder how an amyloidosis type enhancement looks like using this short TI method, and if it would be beneficial to use an inversion time otherwise used for short tau IR fat suppression.
Okay, so we saw amyloidosis with this because we thought it's something like, it was a mixed protocol where we tried to rule out like pretty easy everything, and he had amyloidosis. And you could see it like dark spots, but I think for diffuse LGE, it's not the best method, because then you could use normal LGE, because the distinction between blood pool and subendocardium is not so important in those patients. You see it, but it's not very nicely, to be honest, like there's not much benefit in the sequence. And the second part of the question was something with blood suppression. Sorry,
Yeah, if it would be beneficial to use an inversion time, which is otherwise used for short tau inversion recovery fat suppression, so adopting the inversion time to the one used for fat suppression.
Yeah, I don't know, and I need to try that.
Okay, so we have two last questions, and then we have to move on, I guess. So, did you have any cases of microvascular obstruction, and how does MVO look like with this short LGE sequence?
Yes, actually I have. So because now every time if something is performed for infarction, we perform the sequence. That's very nicely, thanks to my technicians also. It's white. It's white as like I don't have now right now examples, but it's white like remote myocardium.
Okay, so the opposite of the normal one.
Yes, yeah. Yes, like with the thrombi. So it's not like the thrombi because they are white, obviously, but it's very near to the remote myocardium. It's very bright, very whitish.
Okay. So, and the last one, what about 2D single breath hold, single shot PSIR imaging instead of 3D single breath hold to be insensitive to TI and fast? Have you tried to compare these two strategies on the same patient?
I didn't actually. And also in our, the one vendor with PSIR in our hospital, it's manually not, I know it's generally possible, but in this case, it's not, it was not possible to change the inversion time below 150 or 160 milliseconds. So I tried, but I just dropped it because I couldn't make it. I know that it's technically possible, but I wasn't looking deeper into it because obviously with the 3D LG imaging, we are more flexible. And yeah, so I tried to answer that question, but I'm still stuck in it. Yeah.
Okay, so yeah, that's it, I think, from the question side. Thank you very much, Malgorzata. This was really interesting and many questions actually. So
thank you so much. Thank you.
And yeah, then we move on to the second talk. Maybe Ahmed, you can share your screen. Great to have you here, AhmedS.Fahmy from Harvard University. And the paper is about three-dimensional deep neural networks for automated myocardial scar quantification in hypertrophic cardiomyopathy, a multicenter, multivendor study. Thank you for being here.
Thank you for inviting me. Yeah. So in this work, we try to present a deep learning-based segmentation method for quantifying the scar in LGE. So this work is in collaboration with our collaborators from Tufts and University of Toronto. Overview of this work is we try to make it easy for the radiologists not to do this contouring of the myocardium borders and the scar for the different slices in short axis stack of LGE. So we had a multi-center data set from 7 sites covering all 3 major vendors for HCM patients. And we use this data set to train a deep 3D neural network to segment these images automatically. We compared the 3D neural network to 2D neural network because we had a hypothesis that 3D neural networks allow more comprehensive analysis of the volumetric data that we have in LGE dataset compared to 2D neural networks. The summary of results, just before I get into the details, we have excellent correlation between the automatic quantification of the scar volume and the scar percentage relative to the left ventricular mass or volume compared to the manual quantification of both the volume and the percentage LGE. Over all sites and vendors that we had in the data set. We also have better performance obtained from the 3D neural network compared to the 2D neural network. So yeah. So this work is like actually extended or a second study to our 2D neural network model that we presented in 2019, where we we had good correlation between the automatic segmentation of the 2D neural network and the manual segmentation, but we noticed that there was a consistent underestimation of the scar volume. And this is why we moved to a 3D neural network and evaluated its performance. So for the method, we have 1,073 patients collected from 2001 to 2011. All of the data were acquired using 1.5 Tesla scanner. Images included magnitude or phase-sensitive inversion recovery. So we have diverse acquisition protocols. We have an expert cardiologist who manually delineated all the images, myocardium borders, and the scar. All the images were first normalized to an intensity range from 0 to 1, and we cropped all the images to 28 by 128 around the heart. And we also classified the dataset into cases with scar and cases without scar, and then we did a stratified sampling to split it into a training dataset to develop the model and testing dataset to test the performance of the model. We have standard neural network architecture based on UNet architectures. Our convolution kernel was 3 by 3 by 3. We have in-plane pooling, we have dropout, we have batch normalization. It's all the standard processing modules in the convolution neural network. We did also image augmentation to synthetically increase the number of images during training. And we developed a 2D neural network with exactly the same architecture and compared the performance of 2D to 3D neural networks. I'll skip the demographics. Yeah. And one major contribution that we did in this study is that if we have a stack of short axial slices of LGE images, then we divide the entire volume into sub-volumes, smaller volumes containing only 3 slices. And we feed the 3D neural network with a stack of these 3 slices, get the segmentation, and then we form another sub-volume from the next 3 slices and get another segmentation, and then merge all the segmentations together to get only one segmented volume of LGE images. We call this approach sliding window approach for segmenting variable number of slices. For image analysis and quantification, we did linear regression analysis, blind Altman, and we also used the DICE score to evaluate the overlapping between the manually segmented regions and the automatically segmented regions. This figure shows some results from one patient for all slices from base to apex. This is the manual segmentation. Red is the myocardium contours and yellow is the scar contours. I can see visual similarity between the automatic segmentation and the manual segmentation. These are more cases from 9 different patients from different sites. As you can see here, there is good agreement between the automatic and the manual segmentation. We have as you can see here, the problem is different from myocardial infarction scar, where the scar is almost, it's probably a little easier in myocardial infarction segmentation compared to HCM. The pattern of the scar is irregular, spread over the myocardium with different sizes. So it was good that we got good results from this challenging problem. This is the result of the linear regression analysis. This is a manual volume of the scar, and this is the automatic quantification of the volume, and this is a percentage of scar to the segmented myocardium volume. We have good correlation, 0.91 here, 0.88, and the slopes, overall slope between the manual and automatic quantification is 1 for the percentage LGE and 0.93 for the volume. And this is a Bland-Altman analysis figures. And this table shows the correlation coefficient and the slope of the regression analysis for all the sites and all the vendors. So we consistently have better estimation of the scar compared to the convolutional neural networks. And also we had a better overlap between the automatic segmentation and the manual segmentation of both the myocardium and the scar. So for the discussion of this work, I will jump to the limitations and you can go back to the advantages later. So for our method, I'm trying to find, here are the limitations. So the first limitation of this work is that we had all that set. So moving to a newer set of images from newer scanners or probably different imaging sequences like grayscale or gray LGE or short LGE, we need to retrain or at least use transfer learning to use this model on newer data sets. Also, we had only one reader who did this manual segmentation of the data set. One of the reviewers actually suggested we probably need to train the network using manual segmentation by different readers. However, we are not sure whether this would improve the performance or remove the bias to a specific reader, or it would cause more confusion to the network. Yeah, so this is the what I have here. I have some advantages of the 3D over 2D, but I think I will leave it if someone have questions on these issues. Yeah.
Okay, thank you very much. It's a really interesting study, and I saw the previous study as well, and was yeah, quite happy that someone is addressing this segmentation of LGE stuff and to automate it, because it's a really difficult and tedious task if you have to do it in clinical routine. So we have a first question in the chat for you. Do you think that a global CNN algorithm could be implemented for all LGE patterns one day, or that it will be necessary to build separate segmentation algorithms for MI, HCM, amyloid doses, etc., as you did in this impressive work?
Thank you for this comment and question. Actually, this is a very important question, and there is a trade-off between building a separate CNN model for each type of scar or cases and building a global one for all cases. Global one has the advantage of larger data set, so you can have better performance for or robustness for segmenting the scar, and also to be confident in the results, because you'd have a larger data set for testing. Doing it for specific type of scars would give you the highest accuracy, because you limit the diversity of the scar patterns to be specific to this disease, and therefore you can have better accuracy. So I think, and actually we're proposing something like this in our next study, to have a global model that has some way of internally to differentiate between the diseases, and then have different pathways or processing pathway for each type of disease. So we can share common information between the different diseases, like the cross-section of the heart, of the body, but then to be specific to the scar pattern in some internal processing pathway inside the algorithm.
Yeah, that sounds really interesting. So I was a bit surprised about how well this network is doing, because HCM is really not so easy to segment. If you have to do it in clinical routine, our clinicians sometimes are using it as indicator for ICD therapy, for example. So we have to segment it, and it depends on the algorithm you are using. It depends on, of course, the image quality and signal to noise ratio, etc. But especially in HCM, sometimes the LG is really diffuse and not so easy to appreciate. And so surprisingly, this worked really well. But as you said, in your limitations, it's one reader, so maybe it's worth testing it against multiple human readers. Maybe the network, I would guess the network is better than the variation between different human readers, but this would be interesting to see.
I would say it's better for HCM because you don't see frequent HCM cases in clinic. So if we show some of the data to a radiologist who didn't see much HCM cases in the past, I think the machine would outperform his or her segmentation.
Yeah.
But for expert, of course, we are doing below.
Yeah. Okay, so Matthias has a question.
Just a quick one, and I may have just missed that. So first of all, a comment I think where it may be particularly helpful is differentiating artifacts from late gadolinium enhancement, because artifacts can sometimes mimic that, and for less experienced people, it's less obvious that their position and relationship with other anatomical structures give a clue, but it's sometimes, so that's where I see a value. But the question I have is, and as I said, sorry if I've missed that. So it was a purely visual analysis, right? So that is, of course, the training of the algorithm will highly depend on the preferences of the reader. And did you also think of doing that with 3 or 5 standard deviations? So to use more, let's say, more quantitative strategy. I'm not saying that is necessarily better, because all these have also been standardized to visual analysis. So the visual analysis is still, I think, the gold standard. But to make sure that the model is trained using a lot of different inputs.
Yeah, actually, we try to segment only the myocardium, and then we have the contours, and then we can apply mean plus standard deviation, whatever, 5 or 6, or probably full width at half maximum, based on the contours, which easier task to segment only the myocardium instead of the scar. However, if we do this, we get to the point that we have a lot of false positives, false negatives, because the eventually you need manual filtration of the mean plus standard deviation segmentation. So to be semi-automatic, it's one step ahead to make things easier for the manual segmentation, but still you need manual intervention again. So
thank you.
There's a related question to this one. In HCM, there is some consensus in utilizing 6 standard deviations from normal tissue. Does your approach consider it?
How do you think about the variance? Good question.
Yeah, that was actually also related to my question.
Yeah, this is...
And 3 and 5, these are different. For HCM, it's actually maybe less than for infarcts, where you have replacement fibrosis. That where we know 5, 6 standard deviation is good. 6 standard deviation has been used by Martin-Maron's group on HCM, although I think that may be a little bit high, because clearly visually you see more than the 6 standard deviations. So sorry to interject here.
Yeah. So I think the evaluation of the uncertainty is important. Using the three different segmentations for the sliding window to measure this uncertainty, it could be used. But we can also, and we did this, but we did not present it, we can disturb the location of the slice, like doing shift or rotation of the input slice and get different segmentation and assess the uncertainty based on this, on the variation in the results. But this would give us a measure of the uncertainty in our algorithm, which is overall we can evaluate this uncertainty by the other metrics like the correlation coefficient or the dice index. But the uncertainty in the true nature of the scar, whether this is really a scar or not, we don't have very good ground truth to assess the quality, the true quality of the segmentation. But we notice that in many cases, we sometimes outperform. I wouldn't say outperform. We correct some errors in the manual segmentation because sometimes the reader overlooks some of the scar. It's of clinical insignificance, whether it is false positive or false negative. But because the machine learns the average or the consistent or the common mode in the segmentation, sometimes it ignores these mistakes in the manual segmentation.
Okay, so we're running out of time. So one quick question to finalize this really interesting discussion. Was there a validation data set used for optimizing the network before using it on the test data set?
In this study, we did not use a validation data set. We let the network be trained for 2 days. And then we used the final model after almost there was no improvement in the on the training data set, not the validation data set. And we use it for testing. We did this guided by our previous study that we do not suffer from overfitting in this application. And you can see there is no overfitting because the diversity of the images actually prevent cases of overfitting. And if there is overfitting, then it would lead to a lower performance in our method. So we opted to use all that set for training to improve the performance and maintain large data set for testing.
Okay, yeah.
And there is one quick question about the segmentation accuracy in the myocardium. We have a better segmentation for the myocardium in terms of the volume of the myocardium, but we did not evaluate the error in the contours, like the contour distance between the original or the manual and the automatic contours.
Okay, so there are some interesting questions left, but unfortunately we have to come to an end right now. We are already 10 minutes over time. So thank you again very much. This was really interesting and was a lively discussion. Matthias, do you want to give us a preview on the December edition of the CMR Journal Club? You are muted still.
Oh, sorry, I don't know whether you can see my screen. Do you see that?
No, not yet.
Okay.
Yeah, now we see it.
Yeah, okay. Okay, so I just wanted, before everybody leaves, I wanted to announce the next one in December. There will be 2 papers, as you can see here, one from Scientific Reports on abnormal papillary muscle signal on cine-MRI as a typical feature of mitral valve prolapse. And then also related to the dark signal, to some dark signals, hemorrhage promotes chronic adverse remodeling in acute myocardial infarction. And that's an experimental study from Toronto. Both I find very interesting. So I hope that I can welcome many of you next month. So back to you, Bettina.
Okay, thank you. Sounds exciting. So yeah, thank you all for joining us and for the really interesting discussion. It was a pleasure to have you all here, and see you next time in December. Bye-bye. Have a nice evening.
Bye.
Thank you.